Um, Thank you both for a great presentation. I'm obviously an OBGYN as well, so I belong to ACOG as well, and I'm very appreciative of our elected president coming to talk to us. And of course, Michael and I know each other back from UCLA. One of the things I think we suffer from is two things: time for obstetricians to actually talk to patients about nutrition. I think one of the major issues is that the obstetricians never really find the time to talk to patients. They give it to the other workers, healthcare providers in the office. And I want to ask your opinions or thoughts about how to find that time. And I think that would be helpful if they can really find time to do that. The other one that I think may be useful is, what are your thoughts about centering in pregnancy or an interconceptional centering program that actually allows women to actually work together, do exercise together, and then discuss nutrition together as well?
Yeah, I'll start. Thank you. So nice to see you here. California reunion. You're right, we have time constraints. I believe collaboration is key. I have 15-minute visits with my patients. Everything is a 15-minute visit. But I can tell you that I speak with every single patient. I calculate their BMI, ask them what they think their weight should be, talk with them about what I believe diet expectations should be, and I talk with them about exercise. I do that maybe while I'm doing a breast exam, pelvic exam, and chattering the whole time. But I think we have to own it as clinicians, and we have to be there. If it ends there, though, I see them once every 2 to 3 years, it's not going to last. So having the physician reinforce it is one part. Having an assistant, when they are weighed in, give them 3 talking points about why weight is important and what they can do. I reinforce that message, and then finding some way for somebody to do a follow-up phone call or some kind of visit. Just a phone visit is critical, and touching base with expectations. I think the other thing that I've believed with certainly preconception health is following some kind of a chronic conditions management approach where you've got nurses and others who can help touch that patient. When we look at our success with hypertension in the United States, our success with hypertension isn't that we know a lot more about hypertension, and it's not that our medications have changed a lot, but we put patients into programs where we measure blood pressure, we've got outcomes, and we follow up on that. So we have to look at things where we've got to collaborate and follow up that way. Did you want to take the centering?
Sure. Let me just add to that. I think everything we've been learning over the last 30 years of work around quality improvement is that it's not just about making individuals work harder, it's about making the systems work smarter. I think key to making the systems work smarter is to having a team approach and making sure that everybody on the team is putting his or her top strengths to good use. And so while I do believe that physicians have a role in this, there are a lot of other folks who are a lot better at doing nutrition education than we are, and so we really have to think about how do we create that team to provide better care and comprehensive holistic care for women before, during, and beyond pregnancy. And again, here's where I think there may be opportunities afforded by the health reform for us to really think about developing, designing new systems of care that would provide that kind of quality that every woman deserves.
Thank you.
And then centering pregnancy, yes. I think the research is so positive about what centering pregnancy offers what it offers. And it's a matter of helping different medical groups and medical practices, and patients all believe that centering really helps. It's a focused way of approaching pregnancy. Yeah, thank you.
Thank you.
Mm-hmm. Hi, I'm Josephine Chelonia. I work for the North Carolina Division of Public Health in the programs that serve women and children. We've been challenged in our programs, like I'm sure all the physicians and other, is that each of our practitioners, when a client comes in for a visit, they're very focused on the purpose of that visit. Prenatal visits, I think, we do well, focusing on pregnancy. It's the other visits, family planning, child health. And I wondered if you had any thoughts or models where other clinicians who are seeing a part of the family sees that moment to talk to the family as a whole. I think, when kids come into child health, they're there for their well child visit or their primary care visit. There's also some opportunities to offer that family and that woman set some goals with the family about moving towards a healthy weight. I think we're most challenged when families and women are seen in the context of a visit that's not about them. So that's my first question. If you have any successes, to motivate everyone who touches that family, that this is an important issue for the family. So that's one question I have. The second question I would say we're challenged with, at least from a state perspective, is we have fairly good reimbursement from Medicaid and some private insurers to provide women who are really interested in losing weight after their pregnancy or preparing for losing weight. We have good reimbursement for kids and reimbursement during the pregnancy period. And their coverage only goes till 60 days postpartum in our Medicaid package particularly. Mm-hmm. And so we're challenged with not having a source of funding, which as a state agency always is an issue, to serve those women who are interested in really focusing on their weight management during that interconceptional period. So any comments or suggestions you have, I would love to take them back to my state.
Yeah, he gave me the hard one, the first one. One of the difficulties is that we're in silos. And it's very hard to break down silos. And being an obstetrician, my pediatricians are at a completely different site. So I will address something and they're in a different location completely. And then we've got family practice and internal medicine in another location. So it's very hard. I don't have any good examples. I can say that we have to address it, but we don't have a lot of success.
Well, and then in terms of the second question, this is where I do think that the Affordable Care Act is going to make a difference. All of us struggle with the fact that for many women, they lose coverages 60 days postpartum and may have very little access to healthcare when they become pregnant again. So it's really figuring out what's going on in your states and how do we make sure that the resources that are needed to help women achieve a healthy weight after pregnancy become available either through the healthcare marketplace or through Medicaid expansion, if that's what your state is doing, and if that's not what your state is doing, thinking about other alternatives, such as again, 1115 waiver for interconception cure. I think those are strategies that hopefully, as the state progresses, that you all start thinking about in terms of creating those opportunities, those environments, those programs and policies that's really going to have an impact on helping women achieving a healthy weight.
And to reinforce what Dr. Lewis is saying, I've spent the probably last 9 years in advocacy at the state level, just trying to get certain types of care covered. And we can come up with any cost benefit, rationale, you name it. We could come up with data to support why it would work. We never had it happen. This act takes care of the things that we've never been able to do. And people don't appreciate how powerful that is for women's health.
Yes.
Hi, I'm Pat Fontaine, and I'm here representing the American Academy of Family Physicians. And I want to thank you for your wonderful, thought-provoking comments. Along the lines we've just been discussing, I'm particularly interested in the before, between, and beyond component to the pregnancy. I suppose as family physicians, we are, trained to look at the continuity. And I think that one of the things that has held us back is the structure and content of the postpartum exam. We've had a very medical model for that, as you implied. And the idea that, okay, she's coming in, has her uterus involuted, has her, well, years ago, episiotomy healed. Do we get her pap smear now and ask if she's breastfeeding? And then, of course, contraception. But the idea of making that a more preventive, holistic visit, where we address her weight, her exercise goals, and so forth. Do you have any ideas about how we might head more in that direction or best practices there?
Yeah, one of the fun things, when you're in ACOG, we have different regions that we're responsible for. So I was the chair for California, and we had a March of Dimes grant that looked at, we called it the Postpartum Visit Redesign. And we collaborated with, we had family physicians, internists, OBGYNs, MFMs, nurses, a wide variety of people, and said, what are we going to do? And redesigned that and a proposal or recommendation on content so that you can take the information, whatever happened during the pregnancy, what happened during labor, and have algorithms for physicians and providers to feel more comfortable, and algorithms or nice little handouts for the patient to feel more comfortable, realizing a lot of times that was our only touch with the patient, and that was your one opportunity. So we've got that, and I think with Dr. Liu's oversight for our National Maternal Health Initiative, that's one of the areas that we want to use our bully pulpit, if you will, to look at the postpartum visit as a specific topic to redesign for just that purpose. Yeah, because I love the postpartum visit. It's a great photo op. But it's got to be more.
Thank you.
I just well, first of all, I want to thank you for being here, as well as thank all of you for being here. Obviously, for us to be successful, it's going to take a lot more than just OBGYNs to be doing this. It's going to take family practitioners. It's going to take nurse midwives and nurse practitioners. It's going to take health educators and registry dietitians, and really all of us coming together to figure out how do we do this better. How can we better support women, both in terms of gaining within guidelines during pregnancy, as well as achieving a healthier weight before pregnancy and getting back to a healthier weight after pregnancy. I think the key point is the point I made at the end of my talk about thinking outside the box. And that's what we really got to do. Start thinking about the need for redesign of prenatal care, of preconception, interconception care, of that postpartum visit, so that we can really be addressing things that really matter to women's health in the long run.
One thing that strikes me, having just given a lecture on maternal mortality yesterday for some undergraduates in a class on global health, is that we have two different definitions of maternal mortality, one that occurs in the first 42 days postpartum and one in the first year. And truly, pregnancy-related causes of death occur in that whole first year. And we can barely count maternal mortality adequately across all of our states. In fact, the World Health Organization thinks it's 50% higher than we do. But I don't see why we aren't thinking outside that 42-day box to say our post-conceptional care should happen over that whole first year, and we need to see the women again, not just at 42 days. Because at 42 days, we hope they're still breastfeeding. We don't expect them to have lost all their weight. They need a different kind of motivation when breastfeeding ceases, and the reality of those sleepless nights has given way to less sleepless nights and a change in the behavior of their child. Has anybody thought about doing that?
Oh, yeah. No, ACOG is leading. I mean, I can say ACOG is definitely leading the efforts. We've got a large program just coming up with definitions and recommendations. A lot of it's funding. I'm at an HMO. A patient can see me every day if she wants to see me, and her benefits are covered. But right now, for many clinicians, with 50% of their care being Medicaid, they get one visit. You get one visit. So when should you do that one visit? So having those kind of things change are really critical. I can see a patient at 2 weeks, 4 weeks, 6 weeks, 8 weeks, 2 months, 6 months, and it's all covered for her. So working in that kind of system is very liberating in a sense.
Yes.
So then we have to say, how do we get reimbursements adequate so that we can allow more coverage or different things? I think there's some very good research on hypertension. We've got some new guidelines coming out about hypertension. Very clearly, there are a group of women who need to get their blood pressure checked at some other intervals, so we've got to allow that for a visit.
Mike?
Yeah, and let me just talk a little bit about the maternal health initiative that Dr. Conry mentioned. We're gearing up to launch it by Mother's Day this year, a major national initiative to improve maternal health, focusing on 5 components. And the first and probably the most important is improving women's health, again, not only during pregnancy, but before, between, and beyond, but also focusing on quality and safety of maternity care, focusing on public education and increasing public awareness, focusing on developing better public health and community systems. And then the 5th piece of it is improving our research and surveillance. We're in 2013 now. It's unconscionable that we cannot follow women beyond those first 42 days beyond postpartum, and so we can do a lot better than that. And we've certainly been talking with our colleagues at the CDC, at the National Center for Health Statistics, as well as our partners at ACOG and other partners in terms of how do we improve both kind of data and surveillance, as well as research with NIH and NICHD, and just how do we do better in all of these areas if we really want to improve maternal health, reduce maternal mortality and morbidity in this country.
Well, thank you very much. We're looking forward to hearing more about that maternal health initiative as Mother's Day gets closer. I'd like to thank our keynote speakers today, and we're going to move now to our first session.